Good afternoon. Hello, good afternoon. Can you all hear me? Yes? Okay, thank you. Good afternoon, everyone. Apologies for being late. We're waiting for some people who are still at lunch to come and get settled. That's why. Otherwise, we're going to go ahead and get started. I hope you all had a refreshing lunch and are ready for an engaging discussion on one of the most pressing health challenges of our time, cancer care in Africa. Despite significant progress in healthcare across the continent, cancer remains a major public health concern, with disparity in access to prevention, early detection, treatment, and support of survivorship. Socioeconomic barriers, limited healthcare infrastructures, and gaps in specialized healthcare workers contribute to these inequalities, disproportionately affecting vulnerable populations. However, there's hope. Across Africa, innovative solutions are emerging, leveraging technology, community-based interventions, and policy-driven approaches to bridge these gaps. In today's sessions, we'll explore some of those solutions through 3 insightful presentations, each offering a unique perspective on tackling cancer care inequalities and driving innovation. My name is Inga, and I'll be your moderator for today's session. Before we begin, I would like to set a few ground rules to ensure we make the most of our time together. So I would like to all ask you to please switch off your phones or put them on silent mode, and also to try to limit side discussions to avoid distractions. We will have a 25-minute Q&A at the end of all 3 presentations. So I will ask you to please write down all the questions that you might have. Thank you. With that, let's get started with our first presentation. Our first presenter is Dennis Okova, who will be speaking on a study between and within socioeconomic groups inequalities in the uptake of breast and cervical cancer screening among women in Kenya. I will invite Dennis to come and introduce himself briefly before they begin. Over to you, Dennis. Please, let's clap for him.
Okay, cool. Good afternoon. My name is Dennis Okova. I'm a PhD student in health economics at the University of Cape Town. So I hope I won't put you guys to sleep after such a heavy lunch. So I'll do my best. So this study focuses on between and within groups inequality in cervical and breast cancer screening in Kenya. So as a definition, so between group inequalities, I am focusing on disparities between socioeconomic groups or disparities between residence groups, whether living in urban or rural areas. When I talk about between groups inequalities, I'm talking about within group inequalities, I'm talking about disparities in screening within people of the same group. For example, within the rich, within the poorest, within those living in rural areas or urban areas. So as an introduction, as you can see, in terms of epidemiology, cervical, go back please. As you can see, cervical and breast cancer are the leading in terms of incidence in Kenya, as you can see on your left. Then on your right, cervical and breast cancer, they're the leading cause of mortality among females of all ages in Kenya. Next. Then in terms of projections, these numbers of mortality and incidence, as you can see, they're on an upward incline. And this is a cause for worry, especially for a disease that is very preventable and highly curable. So in the case of LMICs, like Kenya, these cancers are diagnosed at advanced stages, which limits treatment options and leads to poor prognosis. However, this can be alleviated through early diagnosis, of which screening is a critical tool. However, unfortunately, in many African countries like Kenya, access to screening remains limited. Next. So this study seeks to examine inequalities in screening for breast and cervical cancer in Kenya over time, over a period of 8 years. 2014 and 2022. And our focus areas will be looking at the trends in screening uptake, disparities in screening, and then we'll decompose inequalities into within groups and between groups effect to see which one drives the inequality the most. Next. So in terms of methods, we used the Kenya DHS 2014 and 2022. And in terms of indicators, for breast cancer screening, we use self-reported clinical breast examination among women aged 18 years and above. And then for cervical cancer screening, we use self-reported measure among women aged 25 and above. So those are our key outcome indicators. Other indicators will be socioeconomic status and residence status. Then we'll measure inequalities. Go back, please. We measure inequalities using two main approaches. The first one will compute concentration indices. So to examine how screening, whether is it pro-poor, is it pro-rich. And then the second measure is the tail index. So this index ranges from 0 to infinity. So the higher the index, the higher the inequality. So we would want to see how this index changes across socioeconomic groups and across residence status. And we would want to decompose this index to understand which of the between group inequality and within group inequality drives inequality the most. Next, please. So we have some results. So in terms of screening prevalence, as you can see for cervical cancer screening, the rates didn't change as much over the study period, 15%, and for breast cancer, more or less the same, 23%. However, this shows that screening rates remain low despite policy efforts. Next. Then let's look at socioeconomic inequalities. First, we'll begin with the concentration indices. As you can see, for breast cancer screening, actually for both screening, the inequalities are pro-rich because both indices are positive. And in terms of changes over time, inequalities reduced just slightly. But however, it means that women from low socioeconomic status groups, they are not screened as much as those from the rich groups. So screening is largely pro-rich. Next, please. Then briefly, let's discuss the tail indices. Remember, I said this index ranges from 0 to infinity. So the higher the index, the higher the inequality. So let's go back, please. Thank you. So as you can see for socioeconomic status, across the three groups, you can see inequalities was highest among the poor, followed by the middle class, then the rich. And in terms of changes over time, there were slight changes over time, but largely the inequalities, women from poor groups are not screened as much as women from richer groups. In terms of residence status, as you can see, women from rural areas face the highest inequalities compared to those from urban areas, judging by the large tail indices. So in summary from this slide, you can see that people who are poor and people living in rural areas are disproportionately disadvantaged when it comes to screening. Next. Then the last component, here we decomposed the tail indices. Wanted to see, because it's made of two components, it's made of the between group component and within group component. So we wanted to see which of the two components drives inequality the most. So starting with cervical cancer screening, you can see that the within group component accounted for between 96.4 to 97% of the overall inequality in cervical cancer screening. Then between group inequality accounted for between 3.6 to 2.9%. So you can see that most inequalities in cervical cancer screening is driven by differences within groups as opposed to differences between groups. And the same is the case for breast cancer screening. So the take-home message from this slide is that Most inequalities exist within socioeconomic groups and within residence groups, as opposed to between those groups. So now, as a policy objective, it's imperative upon researchers and policymakers to identify which of these differences are driving the inequalities among people of the same groups and target interventions towards those people. Next. So in terms of conclusions, we saw that women from low socioeconomic status and those from rural areas, they are the most disadvantaged in terms of screening. So it makes it imperative for us to target interventions targeting these women specifically. So as opposed to large-scale interventions, why not just target these particular groups of women? Then we saw that within group inequalities is the largest driver of overall inequalities in breast and cervical cancer screening. So as a policy imperative, we have to address this within group inequalities. So we have to look for factors beyond socioeconomic status, beyond residence status, and understand what really drives the inequalities among people of the same groups. Is it the differences in educations? Is it differences in access? Is it cultural beliefs? And then we address those inequalities so that everyone can have a level playing field in terms of access to screening services. Thank you so much.
Thank you, Dennis, for the insightful presentation. If you are a policymaker here now, you know what to do and you know where to look for your differences. It's within groups, not between groups. Next, we'll have Blessing Raji, who will present on enhancing self-management in prostate cancer, a digital coaching program in Nigeria. Please let's welcome Blessing Raji, who will also give us a brief introduction of herself.
Good afternoon to you all distinguished experts. My name is Blessing Raji Ayigbe. I am a registered nurse by profession and working with MDoc Healthcare as a digital health coach. First of all, before I proceed, I just want to say appreciate the efforts of the host and the organizers of this conference, and also to you all noble minds seated here. The title of a presentation is Enhancing Self-Management in Prostate Cancer. And this is an efficacy of a digital health coaching program done in Nigeria. I also want to appreciate the efforts of the co-authors of this abstract and to the leader of this team, Dr. Nneka Mobisen. Next slide, please. So without dwelling much of this, this is the outline of the discussion about MDoc problem statements, our approach, the intervention and the result, then the conclusion. MDoc Healthcare is a digital social enterprise, and the focus is to help people live healthier and happier. And this is done by an integrated approach that we came up with, which we call the 4-pillar approach. This approach moves from the use of virtual health coaches and digital nudges to promote health through our AI app called Complete Health. And also, there's what we call Navi Health. Navi Health is an online directory model that was built to help people search for facilities that are nearby. For instance, you have somebody in a new city and the person is confused about where to access quality health. You can easily go through navihealth.ai, search, put in the location you have around you, then you will have the health experts around you, then you'll be able to access the care. The next one is MQN, which we call MDoc Quality Network. As health professionals, we are involved in helping people build quality life, and this can be done through the use of tele-education. So we gather experts, medical professionals together and have a session, tele-education session in there. The last one is the nudge hubs. We realize that the communities need where to go to access health. So we also make use of this approach. Next slide. We all are aware with the challenges faced by the people with advanced prostate cancer, the men living with advanced prostate cancer. And these challenges ranges from the disease condition, managing the knowledge, the physical stress, and all of that. And we decided to put out together approaches, things that we can do to help these men out of these challenges. And that is the use of AI-powered self-care support, the use of the complete health, where members get into the platform, they are onboarded, assign the health coach, and they get nudges. Community health outreach programs done. We go into the communities where we organize prostate cancer screening. So these screenings are not common, but we started doing the screenings on prostate cancer, and you can see me actively there. So this is what we do to ensure that people are aware of the disease condition and are able to manage it. The third one is the cost of cancer care is high, and we've been able to adopt the innovative financing mechanism, and we've realized that over $200,000 in medication financing to members have been achieved. Next slide. So this is actually a retrospective study, a retrospective cohort study that was conducted on 81 men living with prostate cancer from the year January 2022 to December 2022. And all these men, on average of 56 years old, and some of them earn less than $3 per day, and 70% of them were receiving care from the public hospitals. Next slide. So what did we do for them? This is how the Complete Health platform looks like. You sign on the Complete Health platform. You get assigned to a health coach. You can have access to an AI chatbot where you can ask questions, virtually ask questions. Then also we have digital coaches that can send out health education messages, support these members by creating individualized care plan for the members. Next slide. So now, what is digital health coaching? And this is what we've seen that our virtual health coaches, do daily to ensure that they support the health system, right? And this has been seen working because on average, one virtual coaching call goes out to each member every 2 weeks. And each member is also entitled to receiving at least 2 health education messages tailored to their needs, in health education, symptoms, helping them to answer their questions, appointment reminders. Some of them as well also forget that they have appointments with their doctor. So all of these have been done by the health coaches. Then for the multidisciplinary team, we also work with the multidisciplinary team that consists of the nutritionist, we have the mental wellness coach, and the fitness wellness coach as well. The nutritionist engages with these members at least once a month, while also the emotional wellness coach supports this member with their mental states, because we've also seen that the mental states of cancer patients has a lot to do with their treatment journey, like their recovery. So all of these areas have been covered. Then we also realize that the fitness sessions have been attended by the members. At least the members attend 2 sessions the member attends virtual exercise classes by the fitness coaches. So we've also seen that our members even testify with from the benefits received. The benefit received from the sessions, he said, when I started my exercise classes with this coach, I was only able to do it on bed. But right now, he can stand on his feet, move around, and that's actually a great improvement. So results across the self-management and the clinical outcome, from the clinical outcome, we've seen that there is an average systolic reduction of members with comorbidities on hypertension is about 18.90 millimeters of mercury. Then for that of diastolic as well, 4.05 millimeters of mercury. And we can also see that average reduction in the PSA. Then the improvement from baseline of about 30% plus of knowledge. So that means that before they joined the program, they don't really have idea of how to manage the disease condition. But upon joining the program, they're able to access the knowledge compared to before joining the program. Next slide. So in conclusion, we realize that introducing digital health coaching to these members have helped the quality of their life and also strengthening the healthcare system, because we don't just involve just the member. We involve the physicians and the caregivers of these members as well into the care. So it's all about the patient, the caregiver, the physicians. We don't call them patients from our end. We call them members because we do not want to take them away from their doctors. We only want to support the health system and the treatment journey. So we employ that digital health coaching is actually working. We have tested it on 81 men in Nigeria, and it's still ongoing. Thank you very much, and thank you for listening.
Thank you. Thank you, Blessing, for this great presentation. Let's please clap again for her. It was truly insightful and a great example of how technology has been used in healthcare, and especially to tackle the issue of lack of support seen in many of our cancer patients. For our final presentation, I would like to call Stella Matutina, who will present on navigating Rwanda's cancer health benefit package design process. Thank you. And she'll also introduce herself prior to give you her presentation. Let's welcome her.
Thank you, Inga. Okay. Good afternoon, everyone. My name is Stella Matutina Umuhoza. I'm a health economist. I work at the Ministry of Health through Partners in Health. My position, serving as a health financing technical advisor in the Ministry of Health in Rwanda. My presentation is on, I'm going to share the Rwandan's experience in designing a benefit package for cancer services in Rwanda. And we took a very comprehensive approach to make sure that nobody is left behind, to make sure that we are mobilizing resources at once so that we can improve oncology practice in Rwanda. Next. And so I'll give you this specific presentation is focusing on community-based health insurance scheme, which covers majority of the population in Rwanda, and give a bit of the rationale and also take you through the lesson learned and a very brief conclusion. Next. Next. So CBHI is one of the main schemes in Rwanda. It covers majority of the people in the rural areas and the formal sector, and it has increased over time. It started in 1999, and with a coverage of 7%, and currently it covers more than 90% of the general population. And given the expansion of the members and the services, the scheme has been struggling financially to keep up with increasing expenses. And the government decided to keep it financially sustainable so that members can benefit from new health technologies, can benefit from enjoy the life expectancy increase, and also can also benefit from treatment for non-communicable diseases because it is increasing tremendously in Rwanda. And the government decision was, first of all, to commission a sustainability plan in 2019 to understand where are the gaps, what are the weaknesses, so that we can sustain the scheme. And the sustainability plan proposed a number of strategies, and one was to come up with an evidence-based approach to decide on services to be added on the existing benefit package of the scheme. And on top of that, also government put in place other supporting legal framework to make it happen. Next. So the framework, the ministerial instruction, not only was a main, I would say, was the main decision from the government to support the scheme, but also the government set up a committee responsible for appraisal, and also the government also put in place the criteria to be used to decide on the services to be added on the CBHI scheme. So here, my presentation is to take you through the process we use to select new services to be added on the CBHI benefit package. So we look at the existing, we mapped the services, we stratified, we collected the evidence, we gathered the evidence on one sheet, we conducted the appraisal, and then we went through the final recommendations. And I want to say that we started with 10 cancers, with the most prevalent 10 cancers, and the government was happy with that, but they said it's not sufficient because our target as a government, nobody should be left behind. So the recommendation was to expand the benefit package so that we are having a more comprehensive approach and make sure that not every cancer is, at least every patient with a specific cancer will have at least a treatment to support through the cancer journey. So we moved from 10 cancer to, we added 39 cancers. Therefore, our benefit package is covering 49 cancers. Next. So the mapping basically was the first exercise, was to make sure that what are we covering today, what are we going to add. So we know from our list the interventions we are covering. So we use other databases, we use other documentations to expand our list. We use UHC Compendium. We used the DCP. And also we used ICD-11 to make sure that no intervention which is cost-effective is left in our benefit package. And from there, because we have a long list, now we can go to the next step. We can now go and stratify. This should be, next slide. We went on, we have more than 100 interventions that can be beneficial to cancer patients. Now the next step was to stratify which one should be in the basic. The basic services, those are the services that really provide minimum standard of care, especially those can be provided at PHC level. And then we have core. Those are on top of the basic. Now we have core. So those are additional services that are more likely to provide improvement in disease outcome. And now in the last bucket, we have enhanced services. You know that treating cancer is very expensive, so we have those additional services with lesser improvement in this outcome, or those services that provide major improvement in disease outcome, but are cost prohibitive, very expensive, chemo drugs, radiation, most expensive services. So therefore, we move from mapping, we went to stratification. This is an example of stratification. So for breast cancer, for the basic is all about the workup, is all about physical examination. In the core, now you talk about treating with a curative intent. And then in the enhanced, that's now we talk about breast reconstruction, talk about adjuvant treatment, those very advanced treatments. Next. From there now we have to collect evidence, collection of evidence on criteria. So those are the criteria. We collected evidence on the burden of disease for 49 cancer. For every cancer, we have to collect information on burden disease, financial risk protection, effectiveness, feasibility of implementation, cost, value for money, cost effectiveness, priority to vulnerable groups. Those are 10 criteria approved by the government, which were set up front to make sure that there is no conflict of interest in the process. Next. So this is an example of that's what we did with costing. For each cancer, we know how much it costs to provide basic interventions, how much it costs to provide intervention in the core package, and how much it is going to cost the country if we accept to provide enhanced package. Next. Now that's how we went through to generate evidence on a cost effectiveness analysis. We used that WHO guideline of 0.5 times GDP per capita. So this is what we did, and we have evidence. Next. So this is a quick example. On top, you have very most cost-effective cancer interventions. So it means that we can cure uterine and those services. It's very cost-effective. Please, government, invest in these services. This one on top, in the middle, let's discuss. Yes, it's uncertain, but we can discuss. We can check with either other criteria. Can put them on our list. These ones below the list, they are not cost effective. Therefore, should we include or should we exclude? So we have to go beyond cost effectiveness criteria to decide whether intervention can be included in our benefit package. Next. So those other criteria that we measured the burden of disease, we measured the budget impact, we look at the financial risk protection, and we use quantitative approaches to measure those criteria. Other criteria, we use qualitative approaches, like to measure the equity, the feasibility of implementation. So we relied very heavily on the expert because we cannot know whether it's feasible to implement an intervention between 2 to 3 years. But the experts who are on the ground, they know what is fit in our context. So they helped us to do all of this. So that's how we put together all the criteria. We have a very long list of the criteria. Now you have to be smart and summarize. This is a typical example how we prepared our evidence sheet to be presented to our policymakers, to be presented to the experts so that they can guide the formulation of recommendations. Next. So that's how we did. We sit with the expert and then we sit with the committee members. Let's go to the recommendations. So the recommendation says, wow, the benefit package is expensive. From what we are providing today, we need additional $6.1 million every year to be able to cover the 49 cancers, at least providing the very basic package to everyone, every citizen of Rwanda suffering from cancer. Next, that's number one. On top of that, you have to ensure financial risk protection because the government priority is to ensure that services are available, but they're accessible and affordable. So next recommendation, let's go ahead and review our co-payment system, our co-payment structure, so that nobody should be undermined, should be pushed into poverty because of accessing the cancer services. And my conclusion is saying that it's possible. It's possible to do HTA in low-income countries. It's possible to use the criteria, either quantitative criteria, qualitative criteria, but you have to keep in mind, build the capacities, build the local capacities, build your policymaker capacities, build the expert capacity so that you can speak the same language, so that can also build a very strong consensus. Keep in mind, we have very nice books talking about HTA, health benefit package. There are so many unwritten rules and written practices that happen. So therefore, you should learn from your local context. Those are the people who contributed. Thank you for those who attended today's session. And then next, those are the people. So we have local team, we have the expert, we have the committee, we have the academia, we have RBC, we have the Ministry of Health, we have the funders. So thank you very much for your kind attention.
Thank you, Stella, for taking us through a step-by-step run on how Rwanda was able to add cancer services on its community-based health insurance. If you're interested to hear more on how Rwanda is working to achieve the universal health coverage agenda, there will be a session tomorrow in MH2, a follow-up of Stella's presentation. Otherwise, it's time to listen to you, the audience. I would like to call now the presenters back here on the stage so that they can take your questions. I would like to call Dennis, Blessing, and Stella back on stage here, please. We have 30 minutes for Q&A, so if you can please come and take your seats. And I hope you were a very attentive audience and that you noted all your questions, because now I'm going to ask you to keep your questions brief and to the point so we can accommodate as many as possible. Over to you now for the first questions. Yes.
Thanks. Hi, I have a question for Dennis. I'm Rahul Madumba from the University of Southern California, and I found your topic interesting, hence the prodding. But I was wondering how these indices of inequality were constructed and what the drawbacks or pros of each of the measures are, because I think it's a little bit hard for me to contextualize or interpret the findings or how I could actionize them if I don't know how they were actually constructed or measured. So I think some more clarification would be helpful for that. And I guess it also kind of imposes limitations, right, no matter which approach you use. So I think walking us through those would be pretty useful in terms of which of the two to prioritize, or if we should look at something else as sensitivity analysis to test robustness before we get too carried away with the results. So if you could speak to that a little bit, it would be great.
Thank you so much for your question. Yes, thank you for noting the obvious. There are severe limitations to using the tail indices. First, let me cover how it's constructed. So essentially, this index, we have an overall index, and then we have its components. So its components are within group inequality, and then the other one is between group inequality. So the sum of between group inequality and within group inequality gives you the overall inequality. So with that, you can be able to identify where the most inequalities come from, and also for the various subgroups you're interested in. For example, in my case, we're doing socioeconomic status, poor, middle, rich, and we are doing residence status, urban, rural. You're able to see where inequalities lie the most. And ideally, the higher the index, the higher the inequality. And then coming back to your challenge, the problem is this index ranges from 0 to infinity. So it can be any number. So the numbers are so absolute. Just say this inequality is higher than this compared to this. That is the challenge. And the problem with tail indices, it's very sensitive to extreme values. But the beauty of it is it allows for decomposition into between group inequalities and within group inequalities, which is not necessarily the case when you're using concentration indices. I hope I've attempted to respond to your question.
Yeah, I think most of it. I think I get that part. I was just wondering one step deeper, granularity wise, in terms of analytic approach. Is it deviations from the mean, quintiles, or how are we constructing that exact measurement of between versus within group inequality, if that makes sense?
Yeah, we can have a side chat. We talk about the mathematics of it. Yeah, if you're interested in that.
The rest of it makes sense. Thank you.
Cool. Thank you.
Before we take the next question, I would like to take all the questions at once, and then we give the panelists time to answer. I think it will be much better. And if, of course, if before you ask your question, if you can also introduce yourself. Thank you.
Okay, thank you so much. My name is Eric. I went from Chad. I'm going to ask the question in French. If there are someone who can translate for the presenter. OK, thank you. Ma question s'adresse à la première, au premier présentateur. Je n'ai pas pris le soin de prendre son nom, mais j'ai essayé de le suivre. Il essaie de mettre en avant le facteur de richesse pour analyser les inégalités d'accès aux soins. Alors, ma question est de savoir, est-ce qu'il n'y a que le facteur richesse qui peut expliquer les inégalités d'accès aux soins? Généralement, dans le secteur de la santé, on se dit que la santé est coproduite. Alors, ça veut dire qu'il y a des facteurs de l'offre qui peuvent aussi contribuer. Il y a aussi des facteurs de demande qui peuvent contribuer. Au-delà de ça, il y a des facteurs socio-économiques qui contribuent également à l'explication des inégalités d'accès aux soins. Est-ce qu'ils pensent qu'il n'y a que les seules ressources financières qui peuvent expliquer ces lots-là, quoi? Bon. Donc, ça s'inscrit dans une dynamique beaucoup plus multidimensionnelle en santé publique, en fait. Merci.
I think Stella did already the job. Thank you, Stella.
Yeah. So thank you very much.
You didn't? I thought you did. You did? No? Oh, okay, yes. So the question was to Dennis. So he wanted to understand, are there only the socioeconomic factors that influence the inequalities that you've shown? As you are aware, in the healthcare setting, there are demand and supply. There's also demand and supply on top of the socioeconomic factors. I think I've resumed it. No? À peu près ça, d'accord.
Okay, so thank you very much. Again, congratulations on the presentation. So Stella, I will start with you. Your benefit package is just for my information. Your benefit package, have you started implementing it? Benefit package for cancers, have you started implementing it? And if you have, what are the challenges? Because in some countries, like my country, Nigeria, we are finding it difficult to bring in cancer into the national health insurance. And I guess that's what you have done for the benefit package for cancer. You know, you may have designed it, so that it can enter into your health insurance. So that's one. Then Blessing, the tech for the cancers, for those who are illiterate, how do you factor it in? Because although the use of mobile phones, the percentage has increased in Nigeria, But how do you take care of those who are illiterate and cannot even access the phone? So, and then in general, can I just say something? On Sunday, we were arriving Kigali. Midway, one of the passengers collapsed and was almost dead. They announced for availability of physicians in the flight. There were a lot of us, you know. But I want to say that Blessing Raji was one of those that got up, in fact, the key, plus another fair lady, and for almost 1 hour, they were standing, reviving the patient, and we landed with the patient alive. So please, a round of applause for her. So you see, she's not only a health economist or health system expert, she's also a practicing accident and emergency physician. Thank you very much. Eh?
Good afternoon. Thank you so much. My question is, I've forgotten the name, the universal health coverage in Rwanda. I'm Ezra from Uganda Cancer Institute. I would like to first start by thanking the Rwandan government for the efforts they have really taken, because I think around 2016, we used to get quite a number of cancer patients from Rwanda at the Uganda Cancer Institute. And to see the presentation here, I'm amazed that there are quite a number of things for us to equally learn. My first question would be, while I don't know if I just missed it, comprehensive cancer services consists of even prevention and survivorship care. Is that something you're looking to incorporate? The second thing would be, I didn't see radiotherapy services as part of the package that was included. And yet from experience, the biggest out-of-pocket expenditure that patients incur usually comes from radiotherapy services because it's quite expensive. So if it's not something that you're tackling, then the patients would still incur the cost and it would greatly affect them. Thank you.
Thank you to the panelists for the wonderful presentations. Blessing, I have a question for you. The app is quite innovative, but somewhere along your presentation, you said the physicians are carried along. So I'd like to know exactly how the physicians are carried along. If a member joins or subscribes, are you able to have access to their physician and get them on board with your app? That's my question for you. Then I have I don't know if it's a question or maybe just a thought for Dennis. In your last slide, you proposed that interventions should be targeted based on socioeconomic groups or residence groups, just based on your study. But with cancer control programs, it's known that interventions are targeted based on exposure to risk factors, especially for breast cancer and cervical cancer, where risk factors, such as the genetic factors, can easily be, tracked. So do you think that your study is enough to convince the policymakers to target these interventions based on socioeconomic groups?
Thank you. I would like to ask a question for Stella. So we would like to thank the initiative of Rwanda to increase the benefit package for cancer, to increase the number of cancers to be treated.
and being covered by our insurance, community-based insurance. But I would like to see how we are going to increase the access, because we know the cancer treatment is specialty care, which is not found in any health facilities. What are the strategies to increase the number of experts to be found across all different health facilities to enable access for this cancer treatment?
My question goes to Blessing. Thank you, Blessing, for what you have done and are doing to push Africa towards universal health coverage. So in your presentation, you mentioned that most of the cancer patients you work with earn less than $3 a month. And I'm imagining that internet services are not cheap in our setting. So I'm wondering, does your app have options where you offer offline services for some of your activities? For example, the physical activities that don't necessarily need the interventions of specialists. Thank you.
Thank you. Before we take any other question, I would like to give the opportunity to the panelists to maybe answer the questions already asked. So I'll go in line, Dennis.
I'll start with my French brother. So if I understood, you asked if socioeconomic status is the biggest driver of inequalities in cervical and breast cancer screening. Definitely not, but it's just a measure that can be used to assess inequalities. But even if you look at other things, if you look at education status, if you look at levels of knowledge and awareness, they all feed into socioeconomic status. So that makes socioeconomic status a reliable measure for measuring inequality. But that in itself is not enough. Perhaps we need to go and look more into the supply side factors, look at the access to services, look at the distance to facilities, look at empowerment of healthcare workers, look at the decentralization of services, and perhaps use all that to complement this study. Then to my sister Kalechi, you asked if targeting intervention based on socioeconomic status is enough. Definitely not. So our study was two-layered. First, it unearthed that we need to target low-income women and rural living women. And then it went a step further and said that we need to look at those women who are living in rural areas, those who are living in, who are in the low socioeconomic band, and look at those women and not assume that all those women are homogeneous. It's not a homogeneous group. Let us look at the differences between these women and look at what drives those inequalities. The best example will be in cervical cancer screening. For example, you look at epidemiological vulnerability. For example, you go to women living in rural areas and low-income living women and look at those who have HIV among those population and target them for screening, for example. Thank you.
Thank you, everyone, for your good questions. Thank you, Prof. The question is about how far we are with the implementation. So currently, the benefit package has been approved. And approval has, I would say, two levels. The committee, the benefit package committee approved, but the final decision comes to the minister. So the Minister of Health has already approved. And on 19 January 2025, the government, the cabinet of ministers approved. Not only approved the package, it approved new source of fund to implement the package. So now we are developing an implementation plan, which is more comprehensive, not only the service availability, but also other layers. Layers include training providers, expansion of cancer care, co-payments, make sure that the service is available, affordable, but also working on the supply chain. So the process is ongoing, and the government target is to start the implementation by July 2025, at the beginning of our fiscal year. In terms of challenges, yes, challenges are there. So we don't have cancer drugs in Rwanda, so we'll be relying on importation, which means that if there is any disruption in the supply chain, if there is fluctuation in the prices, the budget you have requested might be low. But we hope all the patients are not coming at once. So we hope that we'll be using available resources efficiently and expand our procurement as we have more patients, as we detect, as we improve service availability. And again, technical capabilities to monitor, we have to monitor so that you can make necessary adjustments throughout the benefit package implementation. For ESLA, thank you very much for my colleague from Uganda. Thank you for the generosity, for accepting that people from Rwanda can come and enjoy oncology services in Uganda. And I know someone from my family who come to get treatment in Uganda for breast cancer. So we know that cancer treatment is very much advanced in our neighboring countries, in Uganda, Tanzania. So in terms of our package, it's very comprehensive. As I said, we use an NCCN framework to decide on the intervention to include our package. It means that all modalities were considered, from workup, surgery, treatment, follow-up, and palliative care. And service package is differentiated according to the stage of cancers, because you know that for every stage there is specific treatment which is required. So definitely our package is very comprehensive, but on prevention, the CBHI cannot cover prevention. Prevention is now currently the responsibility of Rwanda Biomedical Center. But if government, as part of the resources we got, there is a room to amplify our prevention and promotion services. We educate our community so that we can detect cancer early enough, which is going to also to improve financial sustainability of the scheme. Currently, we are getting cancer patients very late stage, so which means that we are treating, but with a low rate of success, because you are treating using very expensive drugs, but given that the cancer is already advanced, so the outcome is not there. So our intention is to make sure that services are available and they're accessible to the population. In terms of services we are including, they have to be cost effective and to be also talk about feasibility of implementation. Some of the very trastuzumab, we can't put it in our birth package. It's very expensive. We got it as a donation. So we were trying to make sure that what you are proposing to the government is sustainable, and also it can be improve the outcome of the patient. In terms of I think on the prevention and promotion is not the benefit package, but palliative care now is going to be added in the oncology practice as a part of CBHI. Radiation, currently radiation is covered. Remember, we said we need, on top of existing resources, we need 6.1 million. Radiation is covered, but we have only one radiation center. So now the government target is to establish another radiation center in collaboration with some of development partners. And I know the institution I'm working for now, Partners in Health, it's trying to come up with a costing process to understand how much it costs to establish another radiation center in Rwanda. For Eric, thank you, Eric, for your question about accessibility. I totally agree with you. We have 3 institutions that provide cancer services in Rwanda. We have Butaro Level 2 Teaching Hospital. We have Kanombe Hospital and you have King Faisal. And we know that with the increasing number of with the increasing burden of cancer, with the increasing number of patients, the waiting time, the detection is not very quick. So there are two aspects here. Government is working on physical accessibility. Currently, an assessment study has been done. Now we know additional resources required to start providing cancer services in CHUK and CHUB. So I hope in the planning cycle, government is going to put some money so that we can equip and allocate human resource in those tertiary hospitals so that they can start providing cancer services starting from next fiscal year. Accessibility also implies financial accessibility. Financial accessibility means the 10%, the copayment. So one of the recommendations is to review the copayment structure, the copayment policy, and RISSB is working on that. I hope very recently the Ministry of Health will review the copayment so that either is maybe it's put at a lower stage, not 10%, maybe 5%, or it's completely removed, especially on those very expensive drugs. And we have so many scenarios on the table. We hope government will also take a decision on the copayment structure. Thank you very much.
Thank you very much, Prof, for your question. So I'll be taking the questions now. So, and the first question speaks to those who are illiterate. How do they get to access the support that we give to them? So, the goal of MDoc is to improve digital literacy, and also it is health for all, health services for all. So whoever is using a basic phone can still get calls from the health coaches, then can also still get health education messages that can be accessed by their caregivers. So at the point of onboarding these members to the platform, we get the contact of their caregivers, or if their caregivers are the people we are meeting first, we'll keep their contact, and also we get the information of their treating physician. So we want to know who prescribed the medication for you. So all of these things can be accessed through their caregivers. And some of them, their caregivers have smartphones, while the members have basic phones, right? So they can still get their calls, they can still get their health education messages that can be interpreted by whoever is around them. So, and this has been done also for members who have language barriers. For instance, maybe I'm a Yoruba, then I'm having an Igbo members or patient. So it's easy for us to transfer the member to Igbo speaking coaches or a coach that can attend to them. And this has actually been seen working. Then also for times whereby the members send their health metrics like their blood pressure values, the sugar levels, their PSA results, and all of that. So they share with me as a coach while I input for them on their dashboard. The goal is at the end of a specific period, maybe 3 months, we have something to analyze and see if there is any improvement. So it's either I'm getting the data for them, or their caregivers who have smartphones are getting the data for them, input to them, interpreting whatsoever we want to communicate with them for them. And believe me, even if it's just calls, these members are getting the goal of the service. So for the second question, thank you for asking how are doctors carried along on this app. So from the establishment of care, is being done by the health coach. We at this point, we ask the members who their treating physician is, who prescribed the medication. Also, the goal is also to encourage the member from self-treatment, like self-prescription. So we want to, and you know, cancer drug is not something you can just take from a colleague. Maybe my daddy is taking this medication, so he gave it. So no. So we want to know who prescribed the medication, the treatment journey, the doctor's contact, email address. We get all of those while we are establishing the care. And also sometimes some doctors refer their patients directly to us for this self-care support. Of course, we then have their information with us with the consent of the members. We also let them know that at this specific period we'll be contacting your doctor just because we want to align and understand your treatment journey. So there is this smooth communication between the health coach and the doctors with the consent of the members. So you also see some members tell you, I have to inform my doctors first, and with time we'll get their information. We also give the doctor the improvement, right, that or the goals achieved, the goals set and the goals achieved by the members. Okay, so within this period, this member's high blood pressure was high, but now is controlled. Or, doctor, I realized that for 2 weeks now, these members' so values have been increasing. Is there anything we can do? So we carry them along, and an appointment is being fixed for them. Some appointments might even be an emergency appointment because the doctor knows you. They have to fix this appointment for them. Then, so the third question is, since we know that these members earn less than $3, then how do they, okay, so do they get physical activity? So at some point, maybe a period of 3 months, 6 months, depending on the plan, the goal, and the factors that surrounds it, we carry out home visits for these members with their approval, with their consent as well. So this gives us the opportunity to get to see face to face. And when they see you, we're like, oh, this is the person I've been speaking with. So you see the connection, right? And they are able to trust you more with their care. So yes, we have home visit. Probably we can design the home visit for Lagos. We are visiting Lagos this week. So all our members in Lagos are being covered. We are visiting Abuja this week. All our members are being covered. And so that's we've been doing. So I think the other question was also linked to how are they able to benefit from this program? Looking at the cost of data is expensive, right? I can remember that I once asked a patient to say, oh, daddy, you have been always active on this exercise program. Is the cost of data not too much? And the response I got was, this is my health. If I can access bank apps and I can be on social media, Facebooks and all of that, why won't I be able to get data to access this? And some of them, you have their caregivers, of course, can always sort data for them. So it's because they know the value they are getting, they might not really see it as a burden. And also to some members, I know that they get data compensation. Yeah, so sometimes I could just say, oh, this is just a compensation for your availability. Because one thing about digital health coaching is acceptance. Once they do not accept it or they do not get the insight of it, a member will not be dedicated to it. So we ensure that we encourage, we motivate their dedication to accepting these health services. I think that answers all the question. Thank you very much.
Thank you, dear panelists. We can take maybe one burning question before we close the session. Okay. Thank you. I think you can go back now to your seats. I think there are no other questions that are left unanswered. We've heard insightful discussions today, and I'm sure you all can agree with me. These presentations have shed light on important innovations and challenges in addressing cancer care inequalities in Africa. I encourage all of us to take these insights forward in our work and collaborations. A big thank you to our speakers. Please let's clap again for them, for sharing their expertise and experiences. And thank you all for your participation. This brings us to an end of this session. And I would like to wish you to enjoy the rest of the conference. Thank you.
Hi, everyone. I would just request everyone to just sit down and we'll start in 2 minutes. Do we have a tea break? Oh, okay. I'll check. Just start. Okay. All right. So perhaps in the interest of time, we can just start this session now. So good afternoon, everyone. Welcome to this session on investing in health post-COVID-19. My name is Shivani, and I'm honored to moderate this session as we explore critical insights on how we shape resilient, inclusive, and sustainable health systems in the aftermath of a pandemic. We have 5 excellent presentations lined up today, each offering a unique perspective on successful strategies and policy frameworks to respond to epidemics and pandemics, and the role of community engagement and data. Given the rich content ahead, I'll keep us on track to ensure we have enough time for discussion. So each speaker will have 10 minutes for their presentation. And after all the presentations, we'll have a discussion. So I would encourage everyone to note down their questions and ask them at the end. I kindly request speakers to please adhere to the time limit so we can maximize the engagement since we have 5 presentations. And perhaps now we can get started. So I will invite our first speaker, who's George Edward Tao from Dodova Health Research Center in Ghana. And his presentation is on epidemics as opportunities for social transformation, which discusses a policy framework for addressing the collateral effects of epidemic responses on health systems in Africa. So, George, welcome.
Yeah, good afternoon to you all. I am George Edward Into. Our research actually was done in West Africa among 15 countries, and the focus was on to address post-pandemic response strategies. Each time we have epidemics, we have pandemics, we do have negative effect on vulnerable populations. So we are trying to look at what interventions can be initiated so that in the post-pandemic era, vulnerable groups could be protected. So please, can you go to the slide? Next, please. Yes, so during the COVID-19 pandemic, we realized that we had some level of mortalities. However, if you look at the OPD attendance and if you look at the mortalities, majority of these mortalities were not from direct COVID-19 effect. We had mortalities as a result of poor functioning of other units in the health system. So we call this death collateral death. So in the African system or in the West African setting, each time we have epidemics or pandemics, the effects are not directly from the disease, but rather from other unintended consequences that result to other deaths. So our focus is on how to address the collateral effects, the collateral deaths of epidemics each time they occur. Next, please. So we did this work by using the embedded case study design, where at the holistic level, we try to look at the collateral effect of pandemics, and then at the embedded level, we did a case study from 5 different countries to look at specific areas that need to be addressed as far as control of collateral effect is concerned. And then also we did some sort of rapid assessment where we did stakeholders mapping, we engaged the stakeholders, we also gathered data on the vulnerabilities, the various collateral effects that were presented in West Africa. We also did some sort of sense making where we drew more responses from stakeholders right from the beginning of the process. Next, please. Yes. Yes, so our major focus here is to develop a conceptual policy framework. The idea is that should there be an epidemic in the future or even the COVID-19, there should be some policy tools that would help shape interventions that will regulate or mitigate the collateral effect that comes from response strategies to control the epidemic. So we have the first component of our framework, which looks at defining what collateral effect of epidemic is. Please go on. And then we are also going to look at the scope of this policy framework, the principles and values. Next, please. And then we also have some key approaches and then to address collateral effect. Next. Now, if you say collateral effect, the framing of collateral effect has been done into 2 levels. We have level 1 effect. If you look on the slide, the green box, we have the first effect whereby the moment there is an epidemic, people either die or people either get sick. So there are increase in morbidities or mortalities. These are the direct natural effects of epidemics. Now, in responding to these morbidities or mortalities, the society tend to implement some policies or interventions to reduce the morbidities. And out of these interventions, then we have also the level 2 effect. And this level 2 effect can be targeted or collateral. The targeted effect are the intended effect we want from the policy. Let's say that during the pandemic, we provide more logistics to healthcare providers. It is to reduce the spread of the disease. That is actually a targeted effect of the policies. But then when it comes to the collateral effect of the responses, we had lockdowns. The intended purpose of the lockdown was to minimize the spread of the virus. However, schools were closed. People lost their job in the process. So it wasn't intended for people to lose their jobs, but it happened as a collateral effect of the response strategies. So collateral effect can either be positive or negative. So as we proceed, we will see some examples of negative and then positive collateral effect, and also the targeted effect of responses. Next, please. Yes, so on the left, we have some example of natural effects or the level 1 effects. The first and important of these is the increase in morbidities and then mortalities. And it is important to highlight that even along the line, the healthcare professionals were contracting the virus, and some were also dying in the process. There was also a situation where there was an increase in absenteeism among healthcare professionals because of fear of contracting the disease. So anything concerning morbidities and mortalities are termed as level 1 effect. And if we talk about level 2 effect, which is actually the effect brought about by human-mediated responses to control the level 1 effect, then we have the targeted effect. For instance, on human resource for health, there was capacity building. There were in-service training to capacitate the health workers on how to address or respond to such emerging infections. And then also on other sectors, there was actually the increase of personal hygiene, hand washing practices to actually militate the spread of the virus. The collateral effects, like I said, there was decreased in life expectancy, and that is a negative effect of the responses. And then somewhere also, when you look at health governance, there was actually the importance on multi-sectoral collaboration, and this is a positive collateral effect of the responses. We also have on the housing, there were insufficient support for COVID-19 victims. That is where we're talking about the post-pandemic era. How were vulnerable groups protected, or how were they supported? So that is the collateral effect, the framing of the collateral effect of the responses. Next, please. Yes, good. Yes, so we have some parameters or dimensions of the health system. So we actually use the health system as an entry point when we have to address effect of pandemic responses. It is a health system that suffers the most. And the health system has various dimensions. We have the governance, we have the research, we have infrastructure, we have human resource, we have also vaccines. So these various dimensions of the health system is where our focus is as far as we want to address the effect of pandemic responses. We also do have other sectors, talking about agriculture, talking about social welfare, talking about the housing. These are also different sectors that work collaboratively to also impact on how people experience these various collateral effects of epidemic responses. Next, please. We also do have some other parameters that also actually indicate how vulnerable health systems are in West Africa. Looking at the global burden of disease website, West Africa is already characterized by some level of infections. Talking about TB, we have malaria, which is already there. We also have other non-infectious burdens, talking about maternal deaths, neonatal deaths. And then with the inception of the COVID-19, COVID-19 has also taken a larger proportion of the burden of diseases experienced in West Africa. We also do have other COVID-19 related morbidities. And then also West Africa, or Africa as a whole, the large area for sponsorship or financing of health is out of pocket. So during the COVID-19, a lot of people were more put into vulnerabilities to seek for more care on COVID-19 treatment, and also looking at other sectors, maternal and child health, were rather not having much attention or priorities. So people tend to seek their own way of seeking care, putting pressure more on the vulnerabilities already existing in the West African region. Next, please. So this is a structure of the health system, which, like I said, was used as an entry point. So on this, that we have the health system, we have the leadership and governance as the major arm that controls the other dimensions of the health system. We talk about the human resources for health, which act connectively with how the health service is organized and how service is also delivered. We also have the infrastructure and logistics. So the infrastructure and also interfere with how health service organizations occur and delivered. And then based on the reactions or interrelation between the health human resource for health, the service organization, and then the infrastructure, then it gives rise to the health system outcomes and goals. Are there more morbidities? Are there more mortalities? And then these effects are experienced by the population. They either experience natural effect of the pandemic, they either experience level 2 effect of the pandemic, and it is the vulnerable groups, people who are already marginalized, that experience more of these collateral effects of the epidemic responses. Next, please. Yes, so in the policy framework that we are developing for the West Africa region has some principles and values. The first of it all is responses should be people-centered. When it comes to epidemic responses, it is the vulnerable groups that experience most of this collateral effect. And then also epidemic responses should respect the principle of primum non cere, or first do no harm principle. This is to say that it is better not to act to a situation than to act causing more harm than good. So that is the principle of the non-malfeasance. So we have to adapt that. And then epidemic responses should be used as opportunities to promote equity, including gender equity and social justice. Because when it comes to epidemics, the female-headed household were one of the most suffered vulnerable groups. So how do we use epidemics as opportunities to create some gender interventions for women to reduce the effect of these responses faced by them? And then also importantly, responses should be grounded on context-sensitive evidence, system thinking, multi-sectoral collaboration, and then social trust. Let's look at the context in which the epidemic is occurring. West Africa, how strong is our health system? Let's look at all that sectors. How are they collaborators? And then also the systems thinking. Let's not just look at problems in silo, but let there be some sort of correlation, connection in dealing with it. One health approach is very important when it comes to tackling epidemic responses in West Africa. Next, please. So this is a WHO framework which was used to conceptualize the research, whereby we have the community, the person, and the family in the middle of the eccentric circle, which are impacted by all the sectors. We have the health sector, we have also education, the sanitation. So based on the correlation between the health sector and other sectors, determines the health experience by the people and then the family in the community. Next, please. So talking about key approaches to controlling effect of pandemics, collateral effect of pandemics, the first of those approaches is to first prevent the occurrence of collateral effect of the epidemic responses. And how do we do that? We have to clearly indicate or highlight the vision and then the goals of those epidemic responses to account for collateral effect. We should always anticipate that during epidemic responses, there would be some sort of collateral effect. And how do we protect or minimize it? And this effect could be negative. or positive. So how do we maximize the positive effect and also account for the negative effect? There should also be a way we could monitor the possible collateral effect of epidemic responses. We shouldn't wait for the epidemics to set in and then also for the effect to set in before we begin to act. There should be systems in place. There should be mapping tools to anticipate some of these collateral effects before they actually set in. And of course, no matter how we try to monitor or stop the effect, they will actually do come. So how do we react to the negative collateral effect? We have to put in a way of minimizing mechanisms. We have what we call the panic mechanism, whereby the panic people have tend to interfere on the behavior they adopt when it comes to epidemics. People tend to avoid healthcare facilities with the fear or the panic that they will contract the virus in the health facilities. However, the health system or the facility is a place where we could actually also receive care. So there should be a mechanism to regulate the impact of some of this panic. And then also we look at how to promote positive collateral effect. There are some times that we could do this through monitoring. They should be able to amplify this, and let's also leverage on some of this positive collateral effect. And then finally also we should continue documenting the process for continuous learning, active stakeholders engagement in the process. It shouldn't always have to be that when it has gotten to the climax or the difficult aspect before we engage stakeholders. This should start actively from the beginning and throughout the process. Next, please. And these also are some other examples of interventions that are detailed more in the policy framework that will be used for the West African region. Next, please. So in summary, our project actually highlights the importance of accounting for collateral effects of pandemics to prevent, to also gain benefit from the best positive scenarios. We also look at there should be multi-sectoral approach. We foster systems thinking, gender transformation, consideration in policy formulation, and then also there should be engagement of other actors. Each time we have epidemics, we shouldn't look at things in silo. There should be some sort of One Health approach and collaboration. And then our next step here is that we are actually we have created a learning platform called the We Learn HPS platform, which is a platform to facilitate dissemination of issues related to pandemics or epidemics in the West Africa region. So as time goes by, we're going to share that. So this is the QR code to the primary report that gave rise to this presentation. Thank you.
Thank you so much, George. That was really insightful, and especially talking about things like the importance of leadership and governance and the unintended consequences of a policy, and how important it is to control that, especially in the time of an epidemic or a pandemic. So now, in the interest of time, I'll quickly move on to the next presentation. I'd like to invite Dr. Stacy Orangi from Health Economics Research Institute, KEMRI, Wellcome Trust research program, to present her work on a process evaluation of the implementation of COVID-19 vaccine deployment in Kenya. Stacy.
Good afternoon, everyone. So I'll be presenting work on a process evaluation of the implementation of COVID-19 vaccine deployment in Kenya. So that's the outline of the presentation. Next, please. So as we all know, COVID-19 vaccine deployment was to reach a wider population that targeted adults, which was a bit different to the routine childhood vaccinations. And although it's no longer a pandemic, it's one of the largest, the deployment of the COVID-19 vaccines is one of the largest public health initiatives that has ever been undertaken, especially in low and middle income countries. And this is because it's unprecedented in the scale, in the specificity and the speed of deployment. And so we can still learn valuable insights that may inform future pandemics or rollout of other adult vaccines. So our work aimed to examine the implementation experiences of actors involved in the entire deployment process and its influence on access. So that's the framework that we used. So we conceptualized the work as a process evaluation, trying to see the fidelity of deployment, looking at about 10 different vaccine delivery activities ranging from regulation, planning and coordination, supply chain, service delivery, all the way to demand generation and communication. And then we sought to see how those implementation of those activities influence different dimensions of access, including acceptability, availability, and affordability on the far right. Next, please. So this was a qualitative cross-sectional study that we did in 2 counties, an urban and a rural county in Kenya. And we collected data through in-depth interviews with national level officials, developmental partners, county managers, and healthcare workers. And we analyzed the work through a framework approach in line with the conceptual framework. So in terms of the results, in terms of regulation, we found that the Pharmacy and Poisons Board, which is the Kenya's national regulatory authority, already had systems in place to ensure quick use of emergency use drugs. So they had guidelines for emergency use authorization and expedited imports. They also had systems in place to ensure quality, safety, and effectiveness assessments are done for these emergency use drugs. So having those systems in place was quite useful in ensuring quick availability of these drugs. Planning and coordination was also done both at a national and county level in line with the country's devolved system of governance. And this ensured availability, affordability, and acceptability of the vaccines. Next, please. In terms of financing, so the deployment was largely supported by developmental partners. And this was largely because of some bottlenecks with the public finance management system, including challenges in budget flexibility, timely transfer of funds, and lack of autonomy, especially at the facility level. So next, please. So we can see this quote from a developmental partner that says, the PFM systems in general are slow when it comes to responding to agencies because budgetary control rules around virement, which is switching resources from one line to another. And then there's dependency. The activities have been funded by donors for a long time, so counties have never really borne the full cost of actual vaccine deployment. So in addition, next please, in addition to these initial supply challenges, we found that there were inadequate resources to fully support the deployment activities, which affected availability of these vaccines early on in the pandemic. In terms of service delivery and supply chain, so the strategy evolved over time. Initially, it was just facility-based, but later on moved to include campaigns and outreaches, which was useful in ensuring increased access. And the vaccine administration and supply chain, although initially they were being deployed in isolation, but very quickly they were being integrated with other services in an ad hoc basis. And this was useful in increasing efficiency. So we found there were resource challenges, inadequate HR and financial resources for outreaches, additional supply chain requirements. So we see this MOH official saying that we had to get additional cold chain capacity. Unfortunately, the equipment did not arrive in time. So we had a constraint in space. So they had to start juggling between ordering COVID-19 vaccines and routine vaccinations. And this erratic, next please, this erratic supply and frequent stockouts did influence availability and acceptability. So in terms of monitoring and evaluation, the surveillance system was initially an active surveillance, and that quickly moved to a passive safety surveillance system in both the rural and county and urban county. And the electronic management system was very useful in ensuring real-time data capture. Next, please. So this system was called Chanjo, And you can see this quote by the data manager saying that there was self-registration through the system. It allowed people to get messages on when their next vaccine doses were. It ensured great stock management. They were able to know the number of people vaccinated, compare that with other counties, and also they were able to trace defaulters through the system. So this EMS worked well, but there was a few reported challenges, e.g. downtime, network connectivity challenges, especially in the rural areas. But generally, the electronic management system was very useful in ensuring availability of vaccines, and it limited expiries because it was easy to move the vaccines between the counties. Next, please. Then lastly, in terms of demand generation and communication, we found that there were several strategies that were put in place to increase vaccine uptake. And this ranged from health talks, trainings of community health workers, the use of media to address concerns, stakeholder engagements across different sectors, the use of surveys and rumor tracking tools. Next, please. So we can see this sub-county health manager saying that we had the mandate to engage local media houses, to demystify myths and misconceptions, to engage other stakeholders in other sectors, including the Ministry of Interior and Coordination, where we had the chiefs and village elders. They also had to engage the transport industry, Ministry of Education, and training the religious leaders. But we found that despite these great efforts that were put in place to create demand, vaccine uptake in the country still remained low. But that was largely possibly due to, over time, COVID-19 was perceived not to be a threat or a priority amongst the population. So in summary, some of the reflections from this work that can inform future pandemics or rollout of adult vaccinations as we move towards life course vaccinations is that integration of most deployment activities, if integrated with other existing vaccination efforts, increases efficiency, and these platforms can be leveraged for future new vaccines. There's also a need for resource mobilization for future pandemics. We need to have plans and roadmaps to transition from donor reliance on vaccine deployment activities, have country reform PFM laws, coupled with political engagements to increase facility financial autonomy. In terms of inequities in vaccine access, this highlighted the need to expand capacity for local vaccine manufacturing in the African continent to enable us to be able to respond better to future pandemics. And the use of the EMS for vaccine deployment should be strengthened and expanded to promote equitable vaccine access. And lastly, there is need for future research work to look into why specific demand generation efforts did not work well, especially amongst vaccinations that target the adult population. So thank you very much.
Thank you, Stacey, for those valuable insights. Now I would like to move on to the next presentation, which is our third speaker, Hassan Sibomana from Rwanda Biomedical Center, but unfortunately he couldn't make it today. So on behalf of him, we have Mary Hadley, who's going to present his work. Welcome, Mary.
Yes, thank you very much. I'm presenting on behalf of Hassan Sibomana, who is the division manager for preventative vaccines here in Rwanda. He's currently the PI on the Marburg vaccines study, and he was called away for an urgent meeting on that. So at the last minute, he asked me to step in, but we we did this study together. So I'm very familiar with the study, not so much familiar with the vaccine campaign, but very much with the analysis. You're getting it. So I can start by saying, before the slides come up, that Rwanda, it's great to be able to follow you on this. It's almost, this is almost the same, only Rwanda did meet the target of 70% by June 2022. I think it was the only country in sub-Saharan Africa that did. So we are looking at how come this was so successful here. How did Rwanda achieve this? It's coming, okay. So for myself, I'm currently based in Kenya. I'm director of context and development, but I was working here in Rwanda for 3 years before I left, and worked very closely with Hassan during that time in the same division. Are we getting there? Here we are. Yes. So next slide. Yes. So as you see, Rwanda did reach 70% by June 2022 in vaccine coverage for COVID-19. Next slide. Yes. So one of the reasons, the main reason that that Rwanda achieved these high coverage rates was that there were already very established systems. They had just fought off the epidemic of Ebola in DRC. No cases came across the border, but that was not by chance. That was by very careful management of the preparedness for the epidemic of screening people coming across the border, preparing health workers, vaccinating health workers. They have very, very effective vaccine programs for under 5s. The coverages are very, very high. They're up in the 90s, except for measles, which I think is 60%. They also had recently added adolescent girls. So whereas the vaccination programs were very much linked to the under 5s, they had then rolled out to adolescent girls, which is a much more difficult population to capture. And health workers had been vaccinated. So they had these systems already. They had been working already on both for epidemics and in general systems, strengthening general systems. Next slide. So the objective was to identify the key factors contributed to this success and to provide lessons for the global community in preparation for future pandemics. Next one. So we used the Tony Blair Institute framework. We looked at all components of the vaccine strategy. We examined them in detail. And then we used the 4 pillars of success. We measured against the 4 pillars of success, which is whole government coordination, tailored approach to delivery, digital data, technology infrastructure, and proactive communications with the public as presented by the previous presenter. So this shows all the elements. It's a very complex, and all of these have to work to enable a vaccine strategy to work effectively. The pre-delivery, the delivery, the post-delivery, the cross-cutting, which is the communications and community engagement, IT systems, finance, procurement, regulatory and prioritization, distribution arrival, central distribution hubs, regional distribution depots, local administration sites and service delivery, and then post-delivery, the pharmacovigilance that was introduced, monitoring and evaluation. So all this has to happen well. It has to be well functioning for a vaccine strategy to work well. I'm not going to go in all of these in detail. We haven't got time for that, but we did do this during the study. So next slide. So, as I say, we looked at those 4 areas. Next slide. And for whole government coordination, this diagram shows how many different committees and organization at national level were involved. And then the district level also had the coordination mechanism and the help. Now, this SAG that's mentioned there, that's the Scientific Advisory Group, that was very key, met every week and made recommendations. Many experts there from CDC and across Rwanda and other international participants or members talked every week and then made recommendations to the government, the minister, who then it met, I think, on a weekly basis with cabinet to discuss what they should do. And that was decisions into what messages should be given, who to vaccinate, all the decisions, technical decisions and recommendations were made by the SAG, and that moved upwards. Next slide. Then whole government approach. There was a police post set up, a command post set up, which was also with the police and the Ministry of Defense. Helicopters were used. The whole country came together to work on this strategy to get these vaccinations out as soon as they arrived. They had also recently bought deep freezes in district areas, and so they added the cold chain from the airport to the main center in Kigali and then out to the districts. By Hassan, I remember visiting him to discuss this paper, and he said, "Oh, just wait a minute." And he looked at his phone, and on his phone, every fridge that had COVID vaccines in the country was on his phone with a light. And if it went to orange, he just picked the phone up and said, "What's happened? Can you check your fridge?" And they would check and report back to him if it was a mistake or something had gone wrong. So I mean, it was every single fridge was monitored. So there were no, the cold chain was kept very well. And then sorry, I was still on the one before. Yeah. So and then this tailored approach to reach and vaccinate. So health workers were easy to vaccinate. We knew where they were. The physically vulnerable were also identified. There was a register of the physically vulnerable done with the registers from the health centers of those that had any of the risk factors, for instance, heart disease or cancer, and the age. And if people weren't able to come to the designated center, then the health workers went to the home, went door to door to vaccinate them. That included the elderly. And then prisoners, all the prisons were covered. And we have many refugee camps. The vaccinators also went into the refugee camps, and all the refugees were vaccinated, as well as all the security organs. And the digital response. So Rwanda already had a very, very well functioning DHIS2 and other surveillance databases and they actually, instead of using a separate platform to monitor the vaccinations, they adapted within country. They adapted the DHIS2 to be able to use, and that was because people in the districts, they knew how to use it, and it didn't need everybody needing to be trained again. They could easily update the new modules to the district information officers. All the COVID vaccine strategies were linked to the mobile phone numbers. So even myself, I had to enter my mobile phone number and it showed me my vaccine status. I could print out my vaccine certificates from that. And that way everybody could be covered and monitored when they had the first vaccine, second vaccines. And then there was a unique ID that we were given, which was linked to the phone number. As I mentioned already, the cold chain. And this shows the portal. Next slide. Proactive communication within the public. There was no vaccine hesitancy here that you had in Kenya. That didn't exist. If somebody couldn't, the health workers had a list of who needed to be vaccinated on certain days. If they didn't come, the health workers would phone them up. If they couldn't come, the health workers would go to their home and vaccinate them. There were many health messages. As you know, Rwanda has a very strong culture of using radio, and the radio that was used very much for the messages for the COVID. And there, I forgot to say also before, there were about 60,000 community health workers in the country already working on different programs per village, and these were used to go around to the homes to identify those who hadn't been vaccinated and either bring them in or alert the health worker to go and vaccinate them. Next slide. Yeah. So conclusion, that it was because of the existing systems. The existing systems worked so well in Rwanda that they just used these in order to deliver the vaccine strategy, to implement the vaccine strategy. They had already very high rates of vaccination for children. They had a very good vaccination system with a very good cold chain, including that last mile approach. They had introduced hepatitis B and Ebola for the health workers already, so they had been used to using a different strategy than for the under fives. They had already that in place. And this focus on community that already existed, preventive healthcare, highly digitalized health records, and built-in transparency and accountability. Next slide. I think that was all. Yes, so thank you very much. That's in a nutshell. It was more complicated than that, but in 10 minutes, that's as much as I could put in. Thank you.
Thank you so much, Mary. And that was a wonderful presentation and super insightful, the study itself. All right, so moving on to the next presentation, let me invite Benjamin from the University of Nigeria to present his research on enhancing public health emergency preparedness and responses in Africa through data and knowledge sharing through a scoping review. So if you don't mind, Benjamin, please do share your name because I don't want to butcher it.
Thank you very much. So, as I've been said, so Uzochukwu Benjamin, I'm from the University of Nigeria, okay? Yeah. but you can just abbreviate it as BSc Uzochukwu, right? Okay, so we'll be talking about public health emergency preparedness and data sharing. Yes, so the authors are listed. It's a collaboration between the Health Policy Research Group and the London School of Hygiene and Tropical Medicine. Next slide. So I'm going to use an orthodox method. So I'm going to give you my key messages first, in case she decides to stop me before the end of the presentation, then you can go home with this one. We did note that Ebola and COVID-19 highlighted the need for open data sharing, especially in Africa. And the COVID-19 led to a surge in data exchange. However, it didn't align with findable, accessible, interoperable, and reusable principles. And so challenges exist in data sharing. There are various frameworks for data sharing, and the African CDC is leading this. But at the global level, there are a lot of them that you use for data sharing. Next. So as a way of introduction, public health emergencies require robust and coordinated responses to mitigate the impact on communities and then prevent the spread of infectious diseases. So in this scoping review, so we aim to identify the national, regional, and global capacities to support data sharing in public health emergencies. And we focus on early disease detection, disease progression, monitoring, and strategic adjustments. Okay, so it was a scoping review, and we used the classical methods for scoping reviews, okay? So we searched databases, used combination of keywords, and then of course we screened the full text reading, and then data extraction and analysis. We had our inclusion and exclusion criteria to do this, and the review was reported following the PRISMA SCR scoping review methodology. Next. Oh, very good. This wasn't even appearing in my system here. So this was what we did. So we started with about 777 records, which we screened and dropped some. At the end, we used about 89 sources for the review. And so what were the key findings? We saw that Ebola and COVID-19 pandemics highlighted the need for open data sharing, because this is very important for decision making, okay? And then, of course, the COVID-19 led to a surge in data exchange. There were a lot of data exchange during this period. But the main problem we had was that there was no alignment with findable, accessible, and interoperable methods, okay? And then, of course, the African CDC, they were at the forefront of this data sharing, at least at the regional level. However, there are global frameworks and platforms which we can use to improve international, regional data sharing during pandemics, and we should tap into these frameworks. I have listed them there: the Global Outbreak Alert and Response Network, the Global Initiative on Sharing All Influenza Data, International SARS and Emerging Infectious Consortium, the ECDC, and the Pandemic Influenza Preparedness Framework. So all these frameworks are very, very important in data sharing, and countries should tap into these networks to ensure efficient data sharing during pandemics. Now, it's also noted that these initiatives tend to facilitate the exchange of EPID data, genetic sequencing, research findings, and operational information. And it tends to promote a coordinated and evidence-based approach to pandemic control. So you can see if African CDC improves their capacity in data sharing, and during pandemics, they link up with countries, then we will capture whatever epidemic that is coming on board. However, we noted some challenges in data sharing, and this included the availability of data. There is no standardized approach for data collection and reporting. Then we had issues with technological infrastructure, data fragmentation, lack of trust, and data privacy. A lot of countries were hiding their data. They didn't want to share them for reasons best known to them. They didn't want to stigmatize, and so they were not ready to share their data. And so we recommended that to improve data sharing, there should be improvement in all those areas we have the challenges, including infrastructure improvement, uniform data standards and protocols, collaboration, and promoting ethical data. And so we concluded that open data sharing between scientists and health workers can enhance preparedness and faster response to disease outbreaks, thereby enhancing pandemic preparedness. However, there are challenges which we need to deal with. So thank you very much. So this study was funded by Bill and Melinda Gates Foundation through the IDS. Thank you very much. It was too short, right?
No, it's great. Thank you so much, Benjamin.
I'm very, very uncomplicated. So.
No, absolutely. That was a great presentation and super clear, concise, and direct. So really insightful as well. So thank you so much, Benjamin, for that. I will invite the final speaker, and then perhaps we can get into the discussions and key takeaways and exchange ideas and use the time to just decompress. So our final speaker of this really insightful, excellent session is Precious from Health Systems Consult Limited, who will be presenting her work on strengthening civil society engagement for effective COVID-19 response in Nigeria.
Okay, good day, everyone. My name is Precious Wadire from HSCL. I'm presenting the paper on strengthening civil society response for effective COVID-19 implementation in Nigeria. Just to mention that this paper is born out of the ComSerene project. It's funded by the Gates Foundation, and it was focused on improving, strengthening capacity, coordination of civil society for COVID-19 response. So just as a way of introduction, following the pandemic, the COVID-19, the outbreak in March 2022, after WHO's declaration, Nigeria, as well as other countries, had rolled out some response strategies, response plan to curb the spread and also, curb the spread and address the gaps that had come up. However, what we found, or what the problem was, that we, aside the others, that there was no integration, like the civil society organizations, which currently in Nigeria have a huge number. They do a lot of work across the grassroots levels in community. Their role wasn't clearly specified in those response plan. So what we sought to do was to first coordinate where are these civil societies. It was focused across the 36 states plus one in Nigeria. Where are they at those working at the national level, sub-national level, across multi-sector, the health, the education, across the various sectors, map them, build their capacity, and now go back to the communities to provide some key intervention. Next slide, please. Okay, so this was the approach we took. First, like I mentioned, we mapped both the national, sub-national civil societies. At the end of this exercise, we had the registry, a registry of the CSOs working across the different sectors, what they were actually doing, contacts, and the period or duration of their activities. We did roundtable conversations. A lot of these conversations were virtual. It was during the pandemic season. Co-creation workshops to understand how best can we coordinate their efforts to ensure their voices are amplified. Following that, we came up with some specific indicator matrix that we're going to track across the period. Again, the implementation had 4 major pillars. The first, again, was focused on coordination. That's we strengthened the linkage between the national, sub-national level. The other pillar was on communication. We built their capacity to be able to report what was really going on within the communities, the interventions ongoing, also some of the innovations on how the communities were responding, innovations around responding to the dealing with the COVID-19. We also had the pillar that was focused on capacity building. Here we empowered the CSO to be able to, again, do some sensitization, information sharing, also to report back, because that's an area that wasn't happening. Yes, there are a lot of interventions ongoing, but how well are these interventions being implemented at the community levels? Also, the last part, which is closely linked to that, is the accountability. Here we had state-led accountability dialogue, which was done monthly, where depending on the community, they had sit-downs with the state implementing agencies to say, this is how well, these are the challenges that this community is having, how well have you done this? You had planned to do X, Y, Z, and this is not happening yet. So there was that 4 pillars, coordination, communication, capability strengthening, and accountability. And finally, we did some monitoring work to ensure that there was continuous improvement and the capacity transfer was happening and the project was going as planned. Next slide, please. So in terms of results, what we're able to achieve, it was a very short project. However, we were able to, in terms of coordination, like I mentioned, we now had like a long list of CSOs where they were, what they were actually doing, collaborations that could happen. We linked both the national guys to the sub-national teams. Those collaborations were happening, and again, we could clearly see or clearly say this is where the CSOs were working. We also developed some multi-sectoral guidance documents that, again, ensured there were coordination. In terms of communication, the CSOs developed weekly situation reports. There was a situation room set up. These were local contents on what happened in the community this week. Just to mention that while the project had like, it was across the 36 states plus one in Nigeria, we had like focus states. We called them the deep engagement states. There were 7 of them. And in those 7 states, we had weekly situation reports that were coming in from the different communities where the CSOs were working. They also supported in identifying some innovations, and finally they deployed, there was a hand innovation challenge where they were tasked with identifying some champions, hand washing challenge, several local methods that were used to curb the hand washing challenge that were in the different communities. Finally, thirdly, on capacity strengthening, we built their capacity. We also, aside the training we gave on the other side, we also build their capacity on how to apply for grants to ensure that they have continued funding following this project. We built capacity on information communication and other areas. Finally, on accountability, we, like I mentioned, developed an indicator matrix framework, which was used to be engaged with the states monthly on having accountability dialogue. We also had a national emergency preparedness policy dialogue at the national level, and series of operations research were conducted. I would say a key highlight of the project was that following this intervention we had 49 empowered CSOs that were either doing some demand generation activities, information dissemination, accountability work. However, seven of those states now had the CSOs incorporated into their task force, this COVID-19 task force response team. Next slide. Okay, so in conclusion, I would say while COVID-19 again showed the need for strengthening our health system, we already know the current challenge we have in terms of human resource, the availability, and even those that are available are even migrating out. There's the brain drain and all. The CSOs, the CBOs have shown to be very important actors that can play some or provide some support to the health system as we implement, as we design, as we deploy our projects, interventions, be it at national, subnational levels. It's important that the CSOs, the CBOs are carried along from the design state down to the implementation, because they are in touch with the communities, they know the communities, they know what the context is, and I mean that was shown in the project. So thank you very much. Yeah.
All right, thank you so much, Precious. These are really insightful findings. Now I'll move on to Q&A. So in case you have any questions and if you'd like to raise your hand, I'll just come to you. All right.
Thank you very much, and thank you to all the presenters. So I think my first question, the only question I actually have is for the first presenter, and I think I have sort of attestation to the last presenter's work. So for the first presenter, I know you had mentioned that the assessment or the review was done across different countries in Africa. I don't know the types of countries, but my question then is, something you pointed out in your work was that one of the mediated effects was reduced life expectancy. I just think it would be great to shed more light on that, because I did a study on MPIs, the adoption of MPIs, and I think it's not exactly the human mediated effects, so to say, that had reduced life expectancy. The study was in Nigeria, of course, but because there were a lot of people who had this self-denial about COVID-19 at the time. And you would hear when you tell someone, do you think you're susceptible to COVID-19? They're going to tell you things like, oh, I rebuke that in the name of Jesus, or I'm covered with the blood of Jesus, or say something like, Auzu Billah. And so I think self-denial actually played a role. And I just think you should shed more light on how the response had reduced life expectancy. I think that would actually be helpful for me. And I think as an attestation to Precious's presentation, my organization actually also played a part in HPV vaccine introduction in Nigeria. And I actually played a major role in conducting assessments, trying to understand how HPV vaccine introduction was successful and what were the impacts in the state and all. And one of the things they did, because my organization is a conglomerate and there's a research arm and there's the program implementation arm. So one of the things the program people did was to have the CSOs work with the different states that they were supporting. And I noticed in my discussion with the participants, one thing they mentioned was that their CSOs had something they called vaccine champion. So the vaccine champions were more like those who actually had to cajole residents of different communities or different households on the value of the HPV vaccine, particularly because there was this misconception going around concerning HPV vaccine about wanting to block reproduction for younger girls when they get old. And one very funny story one of the participants shared was that when they got to landlord association meeting, and they were told them they wanted to get their children vaccinated and things like that. And they all denied until one of the landlords stood up like, okay, you'd remember that my wife passed away 5 years ago and I never shared the experience of what really led to her death, but she died from cancer. And it felt like a normal sickness until they learned it was cancer. And so because the man shared his experience, every other person got motivated to then, oh yeah, we're going to get our children vaccinated. Thank you.
All right, thank you very much. Mine is less of a question and more of a information and a bit more commentary. Permit me to sit a bit. I liked what my colleague from Ghana did present, very interesting. And again, what the information on the data gaps does represent. Now I'm seeing this as multiple things that we need to herald into one in terms of how do we get responses to epidemics a lot more efficient, country-driven, and resource-backed. And I'm wondering whether anybody in the room is aware of what the African risk capacity are doing. Very good, silence. Now, the African risk capacity started in 2022, if I believe, and they're an arm of the AU, basically working towards generating parametric insurance for countries for outbreaks and epidemics. So when you see all the frameworks we've all developed, if we don't have resource backing for all of them, it becomes a challenge. And just like we have when we talk of individual patient activities and healthcare service access, same thing with countries. If countries are not sufficiently resourced, this could be catastrophic to them if they deploy all their resources to do that. So that organization is trying to introduce, started in 2022. I think we did a pilot in Guinea, Senegal, Uganda, correct? And I think 1 or 2 countries have enrolled. I think Rwanda is also in the process of enrolling. Nigeria had a conversation with them last week. So again, let me not be their spokesperson, but the reality is that I'm trying to see how all the beautiful work we're doing can actually be pulled together. And I can see them getting value from what I'm seeing here, because the models that they've developed, the triggers that they've developed, could also benefit from some of these frameworks. Data sourcing, the response frameworks, as it were, to help, again, put it as a proper package that'll be useful to countries. So I'm encouraging that if it's possible, let's see how we can adopt a more coordinated approach towards this across Africa. Thank you.
Thank you. So my first question is to my friend Stacy. You said that the process was efficient, but I didn't see how you measured efficiency. So how was it a guesswork? Because I didn't see any result on efficiency. So but you said it was efficient. And then Sarah, I always have something to ask you. Don't say Mary, you're always presenting on behalf of your colleagues. The setup you put looks very expensive. You helicopters, all sorts, whole of government. Any idea of the cost? And do you think it can be sustainable with domestic resources? if you remove donors from the equation, can the country fund such an elaborate delivery mechanism? I mean, I like the way you categorize the pre-delivery, post-delivery, and post-delivery, but what about the cost? Do you think it provides value for money? Thank you.
Any other questions before I just move on to the speakers and I can hand? Yeah, would you like to go and sit down there, or you're comfortable? I think it's fine. I mean, as long as you, okay. Okay. Yeah.
Speakers.
Maybe just before I hand the mic, I just had a question for Stacy as well. Just a very simple question on why you considered Kenyan counties for your study, and how was the selection done for the urban and the rural counties? So what was why was it selected? And then on the Rwandan study, I'll just ask Mary. So there's been a lot of, Rwanda has kind of excelled in a lot of areas, especially healthcare. So community-based health insurance was known to work in Rwanda, but not other countries. But a lot of the papers that I also read, they highlighted that there is some degree of, the perception of the government is slightly stricter, to put it in softer terms, compared to other countries. Do you think that was also found, some of the insights from your study or review, did that also highlight that aspect? Yeah, just those two questions. So perhaps I can go by speaker. I don't know if there was a question for you. You already have a mic. It's okay.
All right, thank you very much for the question. You were asking which countries the study was conducted. So we actually carried out this study in the 15 ECOWAS countries: Benin, Nigeria, all the 15 ECOWAS countries. Yes, and we actually did active stakeholders engagement. And then your follow-up question was how the human responses led to reduction in life expectancy rate. Yeah, thank you very much. So one of the interventions or responses put in place during the COVID-19 was the setup of isolation unit for COVID-19 victims. Now, during the COVID-19 phase, we do realize that there was lack of testable knowledge and evidence on the best practices or approach to actually handle COVID-19 victims. Even as they established the isolation centers, there were some cases where the COVID-19 patients were dejected, or the healthcare professionals were even scared to go into such rooms to care for the patient. And with the COVID-19, so the intervention was, like you did mention, they were rejected because even of the fear of going to contact. At a point, healthcare professionals were even contracting the COVID-19. So how to go within such spaces was becoming a problem. And this subjected some of these patients to NCDs, hypertension sort of rising, thinking about, is this how I'm going to end my life? So the COVID-19 leading to NCD, and then some of them ended their life because of, the frustrations of having not family members even coming to visit them. It was because of the intervention of what? Isolation. I even I had a personal experience. I lost my father with COVID-19 because of some of these protocols which were not well established in a hospital in Accra, in Ghana. So that is how come the COVID-19 responses actually led to a reduction in life expectancy. Yes, 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 yes. Thank you.
Okay, I don't think I have any question. Yeah, but actually I was, you want to ask me a question now? Okay, but I was expecting a question from the African CDC, Elias. He left because we had a lot of issues and there were a lot of publications that we saw that were not peer reviewed. Okay, and because of that, the African CDC did not disseminate, did not share those information, because of the quality. So I wanted him to, because I took him on that. I wanted him to ask, but he left. So you may ask your question now. Let me see. If I can't answer it, I'll pass it back to you.
No, you'll be able to answer. Thank you, Prof. So the question is around how do we ensure that you did talk about data sharing. So I often believe that, or my thinking is, our approach to data collection sometimes is reactive. When it happens, then we start going about how do we collect data as against building up a framework for even data sharing. If I want to share data with another institution, how do I ensure that the way I collect data is, or the way I store my data is similar to the way they do theirs? So when we want to share, it's easier for us to harmonize. So my question is, how can we be much more proactive in this case? And then, are there considerations for ensuring that within the practice of data collection across Nigeria, and then not just limited to specific pandemics or issues, but how can we then institutionalize a standard for data collection so that when it comes to data sharing, it becomes much more easier, maybe like a repository or a central binder where these things can easily be facilitated. So I don't know if your work, whether it captured those things and if there are recommendations that you could share with us.
Yes, this speaks to data quality, okay? And that's exactly what I just finished saying before you asked the question, there are a lot of information out there, but we didn't use most of them because of the quality, okay? And we have recommended that, one, there should be a standardized kind of protocol, standardized framework, especially in the region, okay? Most countries had data to work with, okay? For example, in Nigeria, we belong to the COVID-19 health sector reform, and we had data, internal data to work with, Some universities were, generating evidence that we used, okay? But issue here now is, can you use the same information in Ghana? Can you use it in Cote d'Ivoire? And so on and so forth. So that's why we concentrated on regional and global, data sharing. African CDC is actually a repository of data, when it comes to pandemic and other, epidemic diseases, okay? So for now, we are drawing from them, from the African CDC. WHO is another center, but regionally we are drawing from African CDC. So what we're saying is that those things that are there in African CDC, we should make sure that, they are collected in a manner that, meets up with the standard. Yeah, thank you.
So I'll respond to the first question on the comment that I made, saying that we found that integrating COVID-19 services led to increased efficiencies. So we didn't quantitatively measure efficiency. So it was largely from the interviews. We probably could have done time and motion studies to ascertain that. But what we were getting is previously COVID-19, for instance, vaccination was being done in isolated centers within the facility. Supply chain was also being done for COVID-19 and then differently for routine vaccinations. So what was being reported is that integrating that with existing services was working better. There was better time use by the staff members, better use of resources, and especially later on when not many people were coming into the facility for vaccinations, you'd find the health workers who've been posted in the COVID vaccination centers within the facilities would be there the whole day with one or two patients coming in, as opposed to when it was moved, for instance, in the HIV clinic, in the diabetes clinic. So when you're coming for other services, you're also offered the vaccination. So that was reported to work better. Then the last question on selection of counties. So we went to an urban and rural county that we purposely selected because at the time of data collection, it was when the pandemic was taking place. There were travel restrictions. So we purposely selected an urban and a rural county where researchers were able to easily access. So it was purposely sampled. Yeah.
Right. You didn't have one? Sure. Okay. Yes, I had two questions. I had one from you about the cost. Well, I'm not in the position to represent Rwanda in answering your question, but what I can say is, so I left the UK in '79. I've been working in Africa for 45 years in different countries. And what I saw here was, because all the systems were already set up, it was probably cheapest response. There was, of course, donor money coming in, to donations of vaccines, but the 58,000 community health workers were already there. The helicopters belonged to the Ministry of Defense. I think they weren't used that much. It was just in the beginning, the first lot that came in. They wanted to get them out as quick as possible to the deep freezers in the districts. And after that, it was done with the normal route, with the normal vaccine carriers, with the trucks that they already had, with the freezers that they already had. I do remember that some money from one donor was diverted to pay more ambulances. I think they bought 40 ambulances, but which are now used for other purposes and will be ready for the next response as well. And they've bought another several hundred ambulances since then. But the DHS2 was, somebody just sat in his office and the director of HMS, and he did that himself. He changed the DHS to be able to accommodate, he reprogrammed it, and the district directors were already trained. I do remember my colleague had to go and check on the data, so they did do, when there were big campaigns, he went around and checked on the data quality and made sure that the districts could upload. But it wasn't massively expensive compared with a country that would have to set up a whole system that wasn't already existing and fully functioning. So I think it's almost the opposite to your perception, that it was very expensive. And then I think yours, was it linked to sort of vaccine hesitancy? And yeah, well, again, not speaking as a Rwandan, vaccine hesitancy in Rwanda would be quite difficult, I think, yeah, for the population. Generally, people follow the rules and do what they're told. Yeah. You've seen the speed limit.
Yeah. No, I think, yeah, I did have, the question was slightly more inclined towards the way in which services are delivered, healthcare services are delivered in Rwanda in different situations, and that slightly differs from a lot of other countries. And I wanted to kind of ask more about the governance structures in place and how they might be different from other countries when it comes to epidemics and pandemic.
And also normal routine systems, quality control,
Exactly, yes.
accountability. It's built in everywhere. There are performance targets, there is accountability, there are checks, there are data quality assessments. It's built into the system. It's part of the system. Accountability is really important.
Wonderful. No, thank you so much. Thank you to all the speakers. I'll go around if there's any last questions, and not, then thank you so much to all the speakers. These were wonderful insights and presentations. Thank you for your time, and thank you for everyone for sitting here. If you don't mind, could we have a group photo, please? So we can have one with the speakers and then everyone together. Yeah. Okay.